Thank you, Sweta, for this opportunity. Now we go to a different indication for gonioscopy. So I think these slides are already talked about. So the principle behind gonioscopy, as we all know, is because of the total internal reflection, you are not able to visualize the angle. So now we are talking about the direct gonial lens. The convex surface which is kept over the cornea bypasses or eliminates this total internal reflection. The difference here is there's no mirror in this lens. So you see the angle, you visualize the angle in the same angle which you're seeing, it is not reversed or inverted. So initially it was proposed, or the direct gonial lens was used for pediatric glaucoma, where under anesthesia the angles were observed, and if necessary cornea was clear, goniotomy procedure was done. But now why we are talking so much of direct gonioscopy? Because of the advent of the goniosurgeries and more of cataract surgeons becoming glaucoma surgeon. So you have to learn the art of doing direct gonioscopy. So that is the advent of MIGS with a lot of stents coming up. So you are driven to do gonio-directed surgeries. So the direct gonial lenses, the initial one which was available was a Schwann-Jacob lens, and now we have many more coming up. I'll just deal with it during the videos. You have the glaucoma eye prism, which is the latest one, and the KSOS hands-free gonial lens, and the Katina lenses. So all these patients we are going to do direct gonioscopy is basically because we want to do surgery in them. So what are the prerequisites? The main important thing is the patient selection, because we need to change the neck position of the patient. So the patient should have a neck mobility, and it should be a cooperative patient and a no head tremor, and you should be able to see the angle before you post for the surgery. Now, it is not only the patient's preparation, you also have to prepare yourself, know the landmarks, like what the previous speakers told, you have to know the landmarks, and then practice, intraoperative practice. Before you go and do a surgery, you practice the procedure of doing the intraoperative gonioscopy, and then you have to know something about the lenses also. So anesthesia, yes, it can be done at a topical, but involuntary eye movements can lead to some complications. So when you're a novice surgeon, it's better to block, it builds the surgical confidence and it avoids the potential complications. So now how do you prepare yourself? It is not only you have to prepare the microscope also. It requires a tilt. You should need a microscope where you can tilt the video is not playing, yes. You can tilt the head in. So you have a arrow mark in the microscope. It shows how much degree it is tilted. So you can tilt it around 35 to 40 degree, and then you move the patient's head away from you around 35 to 40 degree, and then ask the patient to look away from you. These are the pre-preparations you do before you go and do the gonioscopy. And because you want to avoid unnecessary neck movement, you can lift the knob under the eyepiece so that you can comfortably sit and do the gonioscopy. So now you know how much to tilt, you mark it and keep, so that repeatedly you needn't keep on tilting to various levels. So you can have a marked one so that you can use when you have a gonio procedure, you can tilt it to the prefixed marks. And the position when you're sitting also is different. In a phaco, you're sitting close and your hands are close to the body. But here you need to space for you to hand, you move to hands and you need some space for the movement. So you place yourself little away from the operating table. So you get more space to move. So which gonial lens to select? Initially only this was available, so we are doing with this. It gives you a 1.2 magnification and it can be autoclavable. Now we have glaucous eye prism. It has an expanded field of view. It is a unique concave geometry, allows precise coupling, and it has an anti-reflective technology also. And the hands-free lenses, and these are the other lenses. Then once you get ready with the patient and the microscope and the lens, now you know you have to dock the lens. So this, the cornea is highly innervated, so it can be painful. So either you put anesthesia drops, or you put a gel, or you can use the viscoelastic, cohesive viscoelastic, coat the cornea, and then you place the lens. So this is the docking video. and then you visualize the angle. So here, it is not just visualizing, you need to have an end-phase view, because your light, like in cataract, it is directed directly downwards. But here you need the light to travel in a coaxial manner, parallel to the parallel to the iris plane, so that you get a visualization and you do not damage other tissues like the cornea or the iris while doing the procedure. So that is the end point. And once you see the angle, then you increase the magnification and increase the illumination too, so that you get a clear view. So identifying the trabecular meshwork, like in a direct gonioscopy, you can get clues by the pigmentation of the trabecular meshwork, and sometimes heme is present. Especially after phaco surgery, when you do a gonioscopy, you can see blood in Schlemm's canal, which helps you in identifying the landmarks. So the literature says that you can stain the trabecular meshwork with trypan blue. So after phaco, you put pilocarpine drops which can constrict, and then dock the gonio lens. And once you get the view, magnify and have an image. Now you can identify all the structures, and then you can start your procedure. This is a bend needle goniotomy being done. So now every cataract surgeon can become a glaucoma surgeon too. But beware, it is only in the early glaucoma cases. So this is the view with the glaucous eye prism. Here you get a more wider view. So take some practice to stabilize both your hands and the coordination. And this is the Catena lens. Here you get a more wider view in all, better than the Schwann-Jacob actually. So the end face view is important. If you're not getting it, you can tilt the head more and then you can focus the angle. So now you're ready for the procedure when you have a proper view of the angle. So what are the problems we get to see when we are doing? Similarly with the indirect gonioscopy, the corneal folds can also obscure your view. And how do you overcome it? When the IOP is too low or the visco is flown out by pressure on the section, again then also your positioning might have, just by the movement of the eye, the position of the lens might have moved. Check and reposition it. And always we need to take time to focus. So when you're focusing initially, you don't focus with the foot pedal, but with your hands you move the microscope, because the finer movement you can do with your foot pedal. Otherwise, once you do it with the foot pedal, then you have a very minimal range of movement and you might find it difficult when you're doing the procedure. So the other problems when you that you encounter is a minimal air bubble under the lens or air bubble in the viscoat, which you've used, can obscure your visualization of the angle. Or especially when you're planning for a surgery with the gonio procedure, a phacosurgeon should select an incision which is more into the clear cornea, so that the blood doesn't come in the view. A mere blood under the lens can obscure the view so that you're not able to see that. So the blood is coming under the lens and you're not able to see what is the angles underneath. So like I told before, if you're not seeing or if the end phase view is not being done, viewed properly, you can have problem in judging the angle anatomy and difficulty in the doing the procedure too. The solution is rotate the head further away, rotate the scope towards you, and tell the patient to look away. If it's still blurry, it might be too zoomed out, or the conjunctiva might be ballooned out, or if it's a corneal edema is present, or if your accommodation is at fault, again you might get a blurry. So first, once you have mastered the gonioscopy, then you can just try with a 26 gauge needle, bend tip, and then go do your bang procedure. You can start with that, and then go, and this is a video which I have already shown you. And then you can move on to the KDB, which is similar to the 26 gauge needle. It is just the more pricey, I'll tell you. But then you can do the same procedure. You do one side and then turn it and do the other side also. So until your hand moves, you can cover the angles. Just have 2 more slides, I think. And then turn it, and then you do the same procedure. The other gonio procedures are the trabectome and the ab internal canaloplasty, and the future of glaucoma surgery is the gonio surgeries. So you have to learn to do a intraoperative gonioscopy also. Now the newer ones are the hands-free gonio lenses, where it's like a retinal biome. You can just fix it under the microscope and your hands are free. So thank you. I think all phaco surgeons can learn and become a glaucoma surgeon. Thank you for the opportunity.
Thank you.